Good morning. Welcome to Liverpool, a city very close to my heart, as Munir knows. It's great to see so many people here. We know that we only pulled this meeting together relatively recently, and so to see so many people turn up, make the effort to get here, to engage in hopefully what will be a great day of conversation and discussion about pharmacogenetics and really about the opportunities for pushing forward to the next stage. So we've got a fairly packed programme, talks this morning, lunch, this afternoon some sort of breakout rooms which we'll describe in a little bit more detail, where people can have an opportunity to think about some of the challenges that we're wanting to address, and then we'll round up the day, and hopefully this will be a start of a number of other initiatives over the next couple of years linked into the Stratified Medicine Pharmacogenetics network as well. And so without further ado, I'm going to ask Munir, who you will all know, to introduce the network and set the scene. Thank you. Thank you.
Morning, everybody. Great to see so many people here. We are nice in Liverpool, so it's great that you're here. And we'll give you a cup of tea later on as well. So I'm going to introduce just the network. As you know, we are the UK Pharmacogenetics Stratified Medicine Network, and this meeting is joint between the network and another network, which is the Pharmacogenomic Methods of NHS Genomic Network. You need an acronym for that, don't you, really? Yeah, so it's too long, but there's need an acronym for that. But as you also know, the network, the UK Pharmacogenetics Stratified Medicine Network, is now supported by the British Pharmacological Society, so I want to thank the BPS for supporting us. And we are going from strength to strength, hopefully, in terms of what we're doing this year. So the next thing that we have is the annual meeting, which is on the 26th of June at the Royal College of Physicians in London. This is Royal College of Physicians North in London, and we have a fantastic speaker lineup confirmed. So hopefully I'll see all of you there as well, in lots of different areas which are going on. Now I want to tell you about another network. So, we're just kind of proliferating these networks and so on. So the UK Pharmacogenetics Stratified Medicine Network, together with the British Pharmacological Society, applied to Innovate UK for these Regulatory Science Innovation Networks competition, which was held earlier this year. And we were awarded a network in pharmacogenomics, which is fantastic. So we are in a discovery phase at the moment. And it hasn't started yet, but it's going to start very soon. And the idea here is to look at regulation. All of us have to do something in relation to regulation in terms of what we do. If you work with a company, if you work in the NHS, if you work with the regulators and so on. And it's a very complicated ecosystem. You have so many different organizations involved. It becomes really confusing. And the processes aren't quite clear. And so what we want to do is to really work with all stakeholders, those in the NHS, those in academia, and particularly with industry. What are your problems? What are your particular issues in terms of regulation? How can we develop a proportionate regulatory pathway as we move forward? And then what we want to do is from this network discovery phase, we're going to be holding at least 5 workshops over the next 6 months on different aspects, looking at different areas, including companion diagnostics, looking at sort of getting it into the NHS, looking at getting into the drug label, etc. And really to understand what the barriers are and how can we develop a proportionate regulatory pathway that is fit for purpose, and it makes the UK really competitive in terms of this area, because it's important, competitive, that allows companies to thrive, competitive that allows academia to be able to thrive, but most importantly, benefits patients in the end. And that's what we want to do, really, to work with everybody in a very co-designed way to be able to take this forward. So this is going to be a major piece of work for the net, which all networks actually, not just this one, but we're going to call this UK Regulatory Science and Innovation Network in Pharmacogenomics. I did apply to extend the day to 36 hours, but they refused, so I have to do it in the 24 hours I have in the day to be able to do this. So it's going to be fun working with all of you to do this, so look forward to seeing you at the workshops over the next 6 months in this. If there are companies that I haven't contacted about this network, many of you I have contacted, but if I haven't contacted you, then please come and talk to me break time so that I can get your details and make sure that you're invited to this, because I want to make sure companies are involved in this in terms of moving forward. So please do come and talk to me. Give me your card so we can make sure that you're invited to some of these workshops. Okay, so thanks very much. I'll stop there.
Great. Okay, so I'm going to have some formatting issues, I can see. I'm delighted to sort of talk to you a little bit about this new network of excellence. So a number of you in the audience have been really involved in this from its inception, but there are people here that probably know a little bit less about the whole concept of these networks of excellence. So these are initiatives that have been sort of developed by NHS England, particularly by the genomics unit there, and have developed from these genomic medicine service alliances. So they're my disclosures. With the genomic medicine service, there's been a number of developments over the last few years. So we all know that genetics, genomics has been a mainstay of clinical care for a number of years. But there's been a bit of a reorganisation within England sort of over the last decade, partly related to the 100,000 Genomes Project, a reorganisation of the laboratory systems, thinking about how we reorganise and deliver clinical services within genetics, and this concept of mainstreaming genetics, so clinicians from different areas are all sort of very much part of that. So whether you're an oncologist or a cardiologist, you have access to the genomic testing support infrastructure you need, supported by clinical genetics. But as part of that, there's been the development of these genomic medicine service alliances. And the alliances really have got a remit to look at genomics and see how it could be used to transform healthcare for better. Okay, so they're forward-looking, looking at ways to develop sort of new projects, look at education, training, supporting the service as such. And over the last few years, they've had a series of national initiatives, national programs, and some local regional programs. And so some of the national programs have been around looking at improving pathways for sudden cardiac death to make sure that the right samples and information is collected in a situation where that happens. But one that we led on with colleagues down in the southeast was one around DPYD. So DPYD, as you know, is a gene very important in the metabolism of fluoropyrimidines, and NHS England brought in routine testing for that. And what we wanted to do was to check, well, was that really happening? Was it happening in the right time frame? Was the information getting to the right places? And there were a number of different questions. You can't just introduce a service and just hope everything's going to be okay. You need to examine that and look at it and then take that learning and improve that. And that's been a great piece of work with Nisha and the team down in the southeast, with Paul Ross, with Munir. And there's been a number of projects that have emerged from that. So looking at the fact that are we offering genetic testing across all racial and ethnic groups, and making sure that that is something that's core of our thinking. Have we got the dosing right? Are we doing that right for rare variants? And there's an ongoing program of work there. Munir's had a couple of local programs of work, one around looking at the role of pharmacogenetics in polypharmacy, one around looking at the role of pharmacogenetics in mental health. And it's not just in the Northwest, there have been projects going on in other parts of the country, so obviously in Central and South, a program around mental health working with Inagene, who are here today. Elvira, who's speaking a little bit later, has been doing an NIHR-funded program that we've linked in with around mental health as well. The team, Paul Selby and colleagues, and Aris over in Cambridge have been looking at how you introduce results into their electronic record system, and we've been providing some support to Jude Hayward and colleagues with Congenica around the HAPPY trial. So there's been lots of activity in the last 2 or 3 years around pharmacogenetics, increasing interest, and then there was the opportunity to apply for this network of excellence. And over the past couple of years, we've been thinking about this program in primary care, which John will take you through, called Progress, and some of the work around that. There's been this creation of a genomic pharmacy team. So in all of the regions, there are pharmacy leads who have been absolutely fundamental, all sitting here in the front, who have been fundamental to driving forward the thinking about how we deliver pharmacogenetics in practice, because we need staff that understand drugs and that they see this as their professional remit. And so pharmacists are going to be absolutely key to supporting this program work. So it's really fantastic that we've seen that change recently. And we've also have to recognise that in the UK, we've got a phenomenal record. There's a number of people that have contributed to that in the audience, but particularly Munir and Anne and a number of others who have led world-leading research programs that then need to be supported and taken forward into clinical delivery. I think in our experience, we've seen it's great to see so many industry partners here today. We've seen a mind shift, I think, in the fact that for diagnostic companies and for other companies, be it around informatics, thinking that there are opportunities in this space to make a real difference in public health. And so a number of you will know this time last year, this paper was published and I think has made an enormous difference to our thinking of, is the evidence there for us to be delivering pharmacogenetics in real life practice? This was the PREPARE study across a number of centres in Europe, which Munir and colleagues were a part of. And so about this time last year, we were pulling together this concept of the network of excellence. So this is a 2-year program of work, which we are leading in the Northwest with colleagues from the Northeast and Yorkshire. And you'll see there, it's quite small, but we can share this information with everybody, that there are a number of work packages. And what we'd like to do today is to describe some of those. We've got some key people to talk through those. So John's going to cover sort of the first whole section around the Progress program of work. We've then got Emma, who's going to be talking about some of the work that she's been doing. We've got Alison here from London talking about some of her work about behavioural attitudes to pharmacogenetics. Munir's going to touch on their program work around cancer pharmacogenetics, and Elvira around some of the work in mental health. And then I'll, before lunch, mention some of our point of care work that we've done as well. So we're not covering everything, but we're covering a number of the things. You'll see there's a work package there on community pharmacogenetics led by David Wright. He's putting in a large program out of Leicester, which is looking to see the role of community pharmacists in the context of delivering pharmacogenetics. As you know, most drugs are prescribed in that community context. And so if we just focus all our efforts on hospitals, then we're missing the vast majority of relevant people. And then we'll touch on some of the opportunities that are emerging that aren't part of these work packages, but a little bit later on we'll touch on for those people that think, well, I don't see something that's necessarily relevant to me here, but I'm really interested, pharmacogenetics is really relevant to my work, I'd like to get involved. Well, let's have a discussion about how that can happen. We don't want this to be a closed shop. We want it to be something that feels supportive and that is an umbrella that everyone can be a part of. And so, it's clear that in the last few weeks, we've even just started to have conversations around some sort of challenging sort of areas that are starting to emerge. What should we do with some of these new Alzheimer's disease drugs around ApoE testing? What does that mean for first-degree relatives? Should they be having testing that might inform their own risk of Alzheimer's? Thinking about when you give a result for a particular drug for a pharmacogene, so like CYP2C19, that gene could have implications for a whole range of drugs, not just the drug that you're prescribing. Where does that information sit? Who takes responsibility for it? How do we surface that within the healthcare system, making sure that's done in an appropriate way? So these are all things that we should be having conversations about and driving forward. It's not to say we've got all the answers or we know what exactly we need to do. This is an evolving area, but we need to explore that in more detail. So I'm going to stop there. I'm going to invite John, who's been working with us for a number of years, to talk about the Progress programme. Thanks so much, John.
Thanks very much, Bill, and hello, everybody. What I want to do as part of this presentation is summarise some of the work we've done to date around the Progress programme, some of our thinking around where things might go over the next few years. And I'm going to presume this is a relatively self-selecting audience and people will have a relatively good understanding of pharmacogenomics. But just to cover some basics, we know that genetic variation is incredibly common in the population. We all have around 4 million differences compared to the so-called reference genome. And the question is, how do we take knowledge of that variation and apply it in clinical practice to improve patient outcomes or practice personalised or precision medicine? We know lots of that variation probably does relatively little. We know that some can be related to rare disease and cancer predisposition, but some can influence how we respond to medicines. So how do we take that knowledge and use it in clinical practice? And that first step is understanding that genotype to phenotype relationship. How does a change in a gene influence how you might metabolize a certain medicine? And you might have built up really robust evidence to say, yeah, we should be testing for that in clinical practice, but you need to ensure there's technological solutions available to actually identify that variant or those variants in a clinically relevant time frame and a clinically relevant setting. And that might be around developing novel laboratory pathways, new point-of-care technologies, or developing informatics solutions to deliver that information. And then once you've done that, you need to apply that in clinical practice as part of implementation studies to show that you're not disrupting normal routine care. We are not implementing pharmacogenomics on a routine basis in the NHS across the majority of the population. So as we begin to think about doing that, we need to check that actually making that intervention doesn't disrupt other care pathways. And then across all that work, we need to ensure that this is acceptable to patients and the public and clinical stakeholders, and we need to do robust health economic assessment to demonstrate that we're adding value through this intervention. And so traditionally, we've been relatively good at this bit in clinical genetics, establishing this genotype to phenotype relationship. That's our bread and butter. What we've not been fantastic at, especially around kind of mainstreaming, if you will, is moving that into the clinic as part of routine clinical practice, so outside of specialist centres, rare disease centres, or cancer centres. And so everyone here will probably know that poor medicine's effectiveness and adverse drug reactions are common and costly phenomena. They're related to a number of factors, so it's critical to understand that pharmacogenetics is not a panacea. It does not explain absolutely all the variation in how people respond to medicines. Poor medicines adherence, polypharmacy, suboptimal dosing strategies are absolutely critical, and other comorbidities and other patient factors need to be taken into consideration. But we know that genetic variation does play a role. Many medicines need to be activated or absorbed by transporters before they can have their desired effects, and large biobank studies have demonstrated that the vast majority of us carry variants that influence the activity of those enzymes or function of those transporters. And so if you've got reduced levels of some of those enzymes, you might have reduced levels of the active metabolite, leading to reduced medicine's effectiveness. And so despite extensive evidence, which colleagues in the audience and groups around the world have built up over the past few decades for multiple gene repairs, there remains a translational gap, and especially in the NHS. There's 26 of those gene repairs with explicit pharmacogenetic guidance from groups like CPIC, the Clinical Pharmacogenetics Implementation Consortium, or the Dutch Pharmacogenetic Working Group. And at the moment, we're probably applying 4 of those in clinical practice, and access to those varies based on clinical context and geography. So we have a translational gap, and how do we address that? Should we address that? And that's really where our thinking sits. And we know this variation is incredibly common in the population, but the medicines that they're related to and the conditions that they're related to are also incredibly frequent as well. These are the costs in the 2021 year from the NHS Business Service Authority of treating conditions related to commonly prescribed medicines like antidepressants, antiplatelets, and pain relief. So you can see that even small improvements in the effectiveness or safety of these medicines obviously could have significant benefits for individuals, but also potential significant cost savings for the NHS and healthcare services as a whole. And so what we've been thinking about as part of the GMSA, the Network of Excellence, is questions along that pathway. And there are a huge number of questions along that pathway, too many to cover in this presentation today. But if we start to think about questions on that genotype to phenotype, so where does the evidence sit for different gene-drug pairs? Who should we target testing towards? How broad should our genetic panels be? If we think about the technology, what should our genetic testing approach be? Should we be choosing panels that cover every variant that we know about, or should it be more targeted based on clinical context? And then how do we get that data around the healthcare system? What are patient and public attitudes towards this type of testing? How do we start to define the cost effectiveness of panel-based pharmacogenetic testing, which is a huge challenge? We're not going to be talking about that in detail today, but that is absolutely critical. When you're looking at the health economic case for single gene drug pairs, that's relatively straightforward to assess. When you think about panel testing, about something that might be available throughout a patient's life, that's challenging. And so dedicated work needs to go into that. How do we quantify the benefits of the reuse of that data and make an economic case for building the infrastructure to deliver that? And then critically, on that implementation space, how does any intervention fit into that complex healthcare environment? So there is a huge amount of work to be done, and that's why this multidisciplinary network approach is absolutely critical, because no one specialty, no one group of people can answer all of these questions. So this is exactly why we need a pharmacogenomics network of excellence. To try and summarize that down into something that I can actually talk about today, I wanted to summarize the rest of the presentation into three main areas, summarizing some of those questions. The first is around the testing. What testing do we think we should do? How are we approaching at the moment? What might that look like in the future? The data elements, how do we take that data and move it around a disparate healthcare ecosystem where everyone's using different electronic records? And then the service, how do you bundle all that together into something that patients and clinicians want to use? Now, what I'm saying today is based on the work that we've done. It is not the definitive law of what is going to happen, but it's something that will hopefully stimulate discussion in the workshops this afternoon. So two kind of main points of order before we go into those spaces. So this is what we're doing at the moment for the most part. We're doing reactive testing on single gene drug pairs. So you see a patient in clinic, you think they need a pharmacogenetic test, you order said test, and then the results are available hopefully weeks or potentially a few months later, and then you can use that to issue the prescription. What we're talking about here for the most part is looking towards a model where we do panel-based testing. So you're not looking at single gene drug pairs, you're looking at implementing multiple gene drug pairs and potentially reusing that data over time. And so there's two models that you can potentially use. There's reactive with planned reuse, which is where you still do the panel-based test, but you do that in a particular clinical setting when a prescription is being considered. So you still have that initial wait time, and we can do things to try and optimize the laboratory processes to get those results as quickly as possible. But then that data within that panel can then be reused throughout the rest of the patient's life. Or you could look towards fully preemptive testing, which a number of healthcare systems around the world are looking towards, where in theory you could do a panel-based test at a set point in someone's life. You've got that data, and then you can reuse that. So you circumnavigate the need for that turnaround time, that wait time. And what I'm talking about for the rest of this presentation is around that particular space. Now, before we go on, what I want to do is kind of look at two core principles that we kind of speak about quite a lot. So principle one, pharmacogenomics is not rare disease or cancer. This country has brilliant expertise in the delivery of rare disease genomics and cancer genomics, and we can take huge amounts of learning from those spaces, but it is not the same. The type of testing that we're doing, the amount of data that we're using, the need for further interpretation is just fundamentally different. The places that pharmacogenomics will be used are just very different from the places where rare disease results or cancer results are accessed. So that is absolutely critical, that if we think about delivering pharmacogenomics using the same approaches, the same infrastructure as rare disease, we will fail. Principle 2, pharmacogenomics is not special. I obviously love pharmacogenomics, but if we treat the results as if we often treat rare disease results, and we think about it with the same cancelling approaches, the same consenting approaches, the same idea that there is potential secondary findings from that data, we need to change the way we treat that data. If we are going to be using pharmacogenetic results just to guide pharmacogenomic, just to guide prescribing, then actually that exceptionalist approach towards genomics is probably not appropriate. So thinking about it as just another biomarker is something that we talk about all the time. We treat it like a renal function, or you treat it like a weight for dosing. And that's something, these two ideas are something that kind of permeates throughout a lot of our work. So with regard to the testing, how do we approach this? So we know that a significant proportion of gene-drug associations are related to a relatively small handful of genes. So CYP2D6 accounts for 25% of the metabolism of medicines, CYP2C19, then SLCO1B1, CYP2C9, and HLAs. The way we think about pharmacogenomic testing, again, comparing this to rare disease, has to be high throughput and relatively low complexity. The type of interpretive steps that are required around most pharmacogenomic testing is not the same as around rare disease. That same intensive bioinformatic input is probably not required using most genotyping or testing strategies. But there are more complex regions. So there's regions HLA, clearly challenging, and CYP2D6, which is subject to copy number variation, hybrid tandems, and repetitive regions. So how do we develop a testing infrastructure that is high throughput, that is relatively cheap, and that is relatively low input from a bioinformatic perspective, while still capturing those complex regions? And the approach that we've kind of thought about at the moment and that we're applying in the context of our work is to almost have a tiered strategy for testing, where the vast majority of patients at present, in the kind of short to medium term, would have SNP genotyping, so relatively small, high throughput panels. And then for those individuals where there is copy number variation, or your SNP panel suggests there's copy number variation, you might move on to doing something like digital droplet PCR to help you quantify that duplication. And in most cases, that will help confirm that copy number variant. But the challenge of phasing CYP2D6 is a real issue. If you want a high throughput test that's very cheap, actually being able to phase which allele is duplicated is sometimes hard using standard genotyping approaches. So for those really complex regions where you need more granularity, which we see being a relatively small proportion of individuals, you might move on to potentially a long-read sequencing approach. And that's something that, as part of the Network of Excellence and our wider research group, we're exploring different approaches to that at the moment. But that tiered approach, where the vast majority of people will have a high-throughput test that requires relatively low interpretation, is something that we're focusing on and something that we see in the short to medium term as being the approach, certainly within our work. And obviously, groups around the world will vary on how they approach this, but lots of people approximate to this model. So we think our current approach aims to balance turnaround time, throughput, cost, and complexity. You're always making trade-offs within any testing approach that you're doing. And we think at the moment, this is probably the most appropriate balance. For most patients and most clinical scenarios, we think a genotyping panel will be sufficient. Where there's uncertainty with the CMV results, you'd use something like digital droplet PCR. And as I said, where you can't phase, you'd look towards using a long-read approach. And HLA is complex, whether you'd include it on the initial panel itself, or that would be a separate offering. Again, that's something that we're considering. And for now, HLA doesn't form part of our basic genotyping panel. But in an ideal world, we would like a panel that was very, very cheap, did all of this, could phase. So maybe we will get to that point in time. But this is where certainly we sit at the moment with regard to our group. But where do we go in the long term? So Maybe a technology will come along that can do all that through a panel test, and it's very, very cheap. But we increasingly see that next generation sequencing data will be clearly a source for pharmacogenomic data that's available in the population. So these data sets exist within Genomics England and with different research groups or different groups around the country, and there will be an analysis, a reanalysis of that data that you could then implement in clinical practice. And increasingly, as those pipelines improve and as the robustness of those pipelines improve, we see that that will be an approach for delivering pharmacogenomics. So increasingly, we see probably a mixed model of how testing happens, but certainly we see next generation sequencing as being an increasingly viable approach. But the testing is probably not the greatest of our challenge. We're very good at genomic testing. We have lots of different technologies, lots are good. Actually, the challenge in pharmacogenomics is how we get that data to people who need it in that clinically relevant format and a clinically relevant time frame. And I would go as far as saying this is by far and away the greatest challenge in pharmacogenomics. It's not the tests you use. It is how you move that data around and how people access it. So we know that variants in variants in CYP2C19 influence the effectiveness of clopidogrel, but the raw data and how we would traditionally maybe report rare disease results is essentially meaningless to the vast majority of clinicians. The people using pharmacogenomic data are not going to be people like me, people like Munir, who look at this type of data all the time. It's people who have had essentially zero exposure to genomics. So how do we move that into something that's meaningful or useful? And most of you will know that pharmacogenomics has a particular nomenclature using star allele format, and then you go through to something called metabolizer state. So these variants in combination mean that this patient is a poor metabolizer for CYP2C19. That maybe starts to mean something to clinicians who don't know much about genomics, but still, it's not really that useful. And so what we feel, and speaking to clinical stakeholders, what they want to see within their electronic healthcare records is not that this patient is star 3, star 5, or carries 2 loss of function alleles, or they're a poor metabolizer. They want to see actionable prescribing guidance, which is built on and based on robust consensus guidance. And so these variants mean that you should consider an alternative antiplatelet. And so as part of our work, we've developed a relatively simple piece of software which can convert this raw genetic data using the guidance from CPIC, the Clinical Pharmacogenetics Implementation Consortium, into the actionable prescribing guidance. And that data is structured, and it's meaningful, and it's automatic. So you massively reduce the need for someone to sit down and pore over this data. And we're able to do that because we are using a relatively straightforward genotyping approach. So that's a challenge, but the biggest challenge is then how we move that data, how we can do that conversion in our laboratory absolutely fine. It's a relatively straightforward proposition. But let's say that data sits inside our laboratory in Manchester. Traditionally, we would maybe send the results to a clinician via post using a letter or a PDF via email. But actually, that's not going to work for pharmacogenomics. It needs to be accessible within the electronic healthcare record, and it needs to be surfaced at the right time. And so the approach we've taken is to separate the data from the applications. So in this scenario, people using Epic, EMIS, System 1, but actually we need to move that data into their electronic healthcare records in a standardized way so you don't get differences in how it's applied across the country. And so by moving that data into a cloud-based repository, you can then either create places that people can go and access and interact with that data, or eventually what we want to do is to push that data directly out into the electronic healthcare record system. And so at the moment, as part of the Progress study, we've created a very straightforward patient-facing portal piggybacking on the Geno system. And essentially, this is linked to the NHS spine. It's relatively straightforward. You drag your output from your assay into an SFTP server. It will then automatically do that interpretive step that we've spoken about. It will then surface the results. So you can search for your patient using the NHS number. We'll pull that patient from the spine. these are fake patients. And so what you will see here is that you see a relatively straightforward, oh, my thing's not working. You see a relatively straightforward interpretation. So they've been recruited to our study, prescribed citalopram. You see that they're an ultra-rapid metabolizer for CYP2C19, and you see straightforward guidance. So that type of result that is straightforward, easy to interpret, we think that's what clinicians want to see. You can go and access the genetic data if you wish, but the data we have is that the vast majority of people simply don't do that. And then, because we've done a panel-based test, you can re-access that data over time. So if this patient comes in and needs statin a few years later, in theory, that data is there. They're a normal function for SLCA1B1, and so you can use a recommended starting dose. So you can start to see how this approach of reusing the data is potentially useful, but ultimately, we've developed that. That is not what we want to do. We do not want to create yet another system that clinicians have to access. The average time of length of a GP appointment is around 10 minutes. If I come along and say, oh, well, I've got a nice pharmacogenomic system you can access, most of them quite rightly will tell me to go away. So what we need to do is to develop something that is surfaced directly within the electronic healthcare record system in an agnostic way. So you're agnostic of EHR provider or CDS provider, and you're agnostic of your genotyping platform as well, which creates flexibility across the system. And the way we've done that is by adopting data standards. So we're working with the Global Alliance for Genomics in Health to develop those data standards using open EHR and then messaging via HL7 FHIR. And so we're working with partners at Clinical Architecture to develop that, and Scott Watson over here has led on that from a Network of England, Network of Excellence perspective. And so we've recently tested this approach, and we know it works, working with colleagues at FDB and using the EMIS system to show that we can surface this data using these patterns. And that's been an incredibly successful collaboration. So we know these patterns work, and we know that they should scale across the healthcare system generally. And so broadly, this is the kind of type of approach we would use. And so what we would like to do if this was scaled is by using this model and by not simply moving the data directly into the EHR, you make sure that you maintain a single source of guidance within the NHS by developing this content management environment. So within that, if there was a consensus that we needed to tweak the guidance around how we prescribed antidepressants or how we prescribed antiplatelets, we could do that. Now, how that's done, how that's monitored, has to be robust. So there will be a single source of the genomic data, but also the guidance itself should be made accessible via open APIs, so partners can access this, use the guidance, but then you're not getting a kind of disparate landscape of some people using CPIC, some people using DPWG. That would absolutely not be appropriate. And our feeling is that that guidance needs to be managed by a central organisation with a central structure around it, potentially like UK PGX, and there needs to be clear guidance around that. And also, we feel it should be available in a human-readable format. So if you want to go online and you want to view what the current NHS guidance is for pharmacogenomics, you can access it potentially via a group called the UK CPA, and you could look at that as a guidance document. But critically, our feeling is that we do not need to replicate the CPIC Dutch Pharmacogenetic Working Group process. They've done brilliant work over the past 3 decades to develop their own guidance. They've done kind of beautiful, very detailed reviews of gene-drug pairs. Our feeling is that we don't need to do that again in the UK, but there needs to be an agreement around which guidance we're going to use, and there needs to be consistency. And that's something that I certainly think that we'll be looking at over the next few years. So that is our approach to the data element. And then the service aspect of this. So we talk about how you package this service an awful lot. And there's a reason that we do that. We think we do that because it fundamentally impacts whether people are going to use your intervention. So there's the kind of traditional model of how we design services in the NHS, and that's people like us sat in a room just saying, oh yeah, we think this is a good idea, let's do this. Or you can go out and ask people, and you can go out and ask people through interviews or focus groups, or you can do it in kind of structured quantitative ways. And so we have, working with the health economics team, used something called a discrete choice experiment. And whenever you make decisions in life, you might not know it, but you're making trade-offs between things. The brand of flour you buy in the supermarket or the car you buy, you're making trade-offs between different alternatives. And so here, I'd like a Bugatti, but I can't afford a Bugatti, so I might get a Ford KA. So I'm making trade-offs between cost, but clearly I really like the Bugatti. And so if you do that and present options to people that are structured in a systematic way, and you do that iteratively at scale, you can start to draw out the attributes that drive uptake. And we can do that in healthcare as well. So we've undertaken discrete choice experiments in 2,500 members of the public and 300 healthcare professionals as separate discrete choice experiments. So these are currently under review at the moment, but essentially what we did was we presented different pharmacogenetic testing options to all of these stakeholders, and we presented a number of options to people, and they simply just had to pick. If you wanted to choose, which one would you choose? Or if you didn't want to choose either, that's absolutely fine. And we did that in the context of joint pain, and we did it in the context of low mood. And so what you can see for the patients here is that we're asking them, okay, you've got difference in turnaround time, you've got whether you've got access to your own results, you've got information on whether that data is used in the future, so it might just be your GP, it might be regionally, or it might be nationally, and then the type of test. Do you want a blood test? Do you want a swab test? Or do you want a saliva test? And then with the healthcare professionals, it was slightly more complex. We looked at turnaround time, but we also tried to measure the chance of the medicines being effective, the chance of an adverse drug reaction, how broad the data was presented, so single gene drug pairs versus huge amounts of sequence data, and then how they access the results, whether it's via letter or electronic healthcare record. And this is why design is absolutely fundamental, and this is why we need to think about it at the early stages. So what you can see here is the predicted uptake from different models of pharmacogenomic testing. And in the base case, this is where you've got this is using what we would imagine current infrastructure if we were trying to deliver panel-based pharmacogenetic testing, what it would look like. So no reuse of the data, no patient access to the data, no access, so it's blood testing and a turnaround time of approximately 20 days. And you can see that uptake is around about 50% if you were to try and deliver pharmacogenomics using current infrastructure. But what we found was that, and you can see here, we've used base case and you just add on each variable. And using this optimized service that you can see here, patients wanted that data to be reused regionally, access to the data, cheek swab testing, and obviously a quicker turnaround time. And what we saw was that patients having access to their own data was the single biggest predictor of whether they wanted pharmacogenomic testing, which we kind of knew from interviews, but it was a surprise just how powerful that was. Patients fundamentally want access to their own data. So this was an incredibly useful exercise for us. And then we saw similar patterns when asking clinicians as well. So our base case here is that they're getting results via PDF. We're doing single gene testing, and you've got a turnaround time of around 20 days. And this is modeled over between, so you've got pharmacists and you've got GPs that are separated because we saw heterogeneity between the two groups. And you can see it's modeled over different chances of effectiveness and different chances of an ADR. And what we saw was that they wanted the results in the EHR. They wanted narrow panel testing, so people didn't want lots and lots of information thrown at them, even if it was contextualized. They wanted clear, actionable information, and obviously they wanted a quicker turnaround time. And EHR integration, getting that data directly into the EHR, especially for GPs, was absolutely critical. If you said, oh, we're just going to deliver this via letter, people didn't want it. So these types of studies have fundamentally impacted how we're approaching our design. And as many of you will know, we're delivering the progress study at the moment. And so we're part of phase 1. And this is, we've given pharmacogenomic prescribing tools at the moment, Geno, to practices across the northwest of England. This is on a research basis, recruiting patients who've had antidepressants, statins, and PPIs. And we're looking at a number of process outcomes at first. So can we do this? Can we do it in a clinically relevant turnaround time? And how is that data being used? And at the moment, we have got a relatively, actually not relatively, the lab have done an unbelievable job at optimizing their processes. And once the sample is in the laboratory, we're seeing a turnaround time of around 3 days. And we're able to return those results with a median turnaround time of around 5 working days from the patient being seen in GP practice to the results being delivered to them. There's minimal hands-on time in the lab and essentially no bioinformatic input required. And we've got about 150 patients recruited at the moment, and we're seeing a change to prescribing in around 30%. So we think that this is working, and we're looking to scale this. So as part of phase 2, the plan is to expand recruitment geography, and we'll be looking at opening sites in each of the GMSA regions. We are completely revamping our approach to recruitment. So we're moving away from traditional recruitment models where we sit down with a patient or phone call. We've just had REC approval for a completely e-consenting model. Phone consent is available if they don't want that, and then samples being returned via the post. So we have hopefully learned from what we did in phase 1 and improved that process. So that'll be launching over the next few months. And we're looking at integrating with other EHR providers. So we've just demonstrated that we're able to deliver these results within the Epic infrastructure, and we're looking at doing this with System 1 as well. And then the point of all of the network of excellence is how do we take all of this learning, all of this knowledge, and apply it in clinical practice and roll it out as a service? What does that look like? And so this is fundamentally what we kind of see in the future. We'll work with other partners, so the GLHs, Genomics England, to access that sequence type data, store it as consistent data standards, and be able to have that agnostic, interoperable model. And then you see huge opportunities if you're able to deliver that. If you can capture data from the electronic healthcare records, you can create almost a learning healthcare system where you start to look at the value of pharmacogenomic testing in practice. You start to look where the health outcomes differ by patients who've had pharmacogenomic testing. And if we can structure that right, there's huge opportunities. And then potentially allowing that data to be accessed with the proper controls and the proper regulation from Progress RX into patient-facing platforms is something that we know patients want, and we have to begin to explore what that means in a design way, how they look at that data, but also what that means for the healthcare system as a whole and the behavioural impact of that as well. So kind of bring these principles up again. I think it's really important that we consider pharmacogenomics to be a distinct and separate pillar of our genomic offering in England. It is not the same as rare disease or cancer, but we can learn a huge amount from it. And it's great, but it's not special. It's a biomarker that can be used to inform prescribing. So happy to take any questions, but thank you very much.
Yeah, so John, completely fantastic, first of all, to say. I mean, there's such an enormous amount of work going on. We're running a little bit over time. John and other members of the Progress team will be around all day. So Scott's here, Jess is here, Videa's here, a number of us are here. So the recruitment team are at the back there as well. So if you've got questions about it, we're very happy to talk to you about it. There's time for one question if anyone wants to ask. Anne, fire away.
This is a very quick question. You talked about regional rollout. I'm very worried about this. What do you mean by region? Do you mean Manchester only? Do you mean the Northwest? Do you mean England? Or do you mean all of the UK? Because I think this is quite an important issue.
Yeah.
And in general, I would have thought that the whole of the NHS needs access to individual data, not just regional.
So I think when I spoke about regional rollout, that was a part of the DCE work, and that was so patients, when you gave them the option of do you want your data to be available nationally or regionally, when you looked at uptake, what they wanted, they liked the kind of way it was framed if it was a regional offering. If it was national, for some reason, that uptake dropped off. So I think that's about the way we frame this. From how we actually do this on an implementation basis, you're right. If we just do pilot after pilot after pilot after pilot, you end up with regional kind of pockets of excellence. And so hopefully after this, we will move towards a national model. We can't just keep doing pilot after pilot.
Because you might end up with a postcode lottery, which
Absolutely.
is the last thing you want here.
Yeah.
Yeah, so Scott, did you want to just jump in?
Sorry, Bill. It's better if people use the microphone because it's
Oh,
recorded.
of course.
Yeah, yeah. Join later on.
There you go, Scott.
Yep. Apologies. Just quickly, so from a solution design perspective, we're geographically agnostic. So the way that Progress works, separation from the labs, we've designed it so that it could work, in theory, international, because we're using GA4GH, we're using open fire standards. But obviously, as we iterate and roll this out, we're proving it within region and expanding beyond there.
Perfect, thank you. Just a point, I suppose, I see Rich Scott here from Genomics England, that one of the things that we found very interesting, which is clearly relevant to your programme of work and other people that are working at a national level in sharing data, because of some of the feedback we had is that there's this nervousness about individuals feeling that their data is available across the country to, be it researchers, clinicians, that anyone can have a look. They really like the idea of their local hospital, their local GP, people in their sort of frame of reference having access to their data, but there certainly is a nervousness. And I think that's because of some of the initiatives that haven't quite worked so well. And so a lot of your work and others in building up that confidence in how that data can be used and used in a way that is to people's benefit is going to be really, really important. You know, it was quite surprising to see that. John, thank you very much once again. Let's move on and let's find opportunities to bring that, some of the things you've raised into discussion through the course of the day. So next, it's my absolute pleasure to invite Emma Magavern to the stage. Emma is based at Queen Mary's, has been doing, you don't need a long introduction, everyone knows you, but you've been doing some great work with Genes and Health and other programmes of work with Mark Caulfield and others. So Emma, thank you for joining us today.
Thank you, and thanks for inviting me to speak about some of the research that we've been very fortunate to be able to do with the Genes and Health cohort study, and also some of the work we hope to do with the wonderful network of excellence that so many people here have put in so much work into organising. So pharmacogenomics, of course, John explained a lot of this. When we think about the ways that genetics can explain some of the inter-individual variability we know exists in drug response, we can talk about two broad pharmacologic pathways, one being pharmacokinetics, what the body does to the drug, and the other being pharmacodynamics, what the drug does to the body. So I want to focus specifically on pharmacokinetics and metabolism, so how variants that people have in the genes responsible for metabolism can impact on some of that inter-individual variability in risk of an adverse drug reaction or efficacy or inefficacy. So, cytochrome P450 enzymes, hepatic enzymes responsible for the metabolism of many of the medications that we take. And as John illustrated already, it's the diplotype that's important here. So one copy from mum, one copy from dad. And if you get one copy from a parent that has a loss of function allele, so it produces a non-functional enzyme, you could be an intermediate metabolizer, so you'll metabolize that less well than if you had two functional copies. And if you get two copies, you'll be a poor metabolizer. So simplistic example of how that would work in terms of converting that genotype to the phenotype. Personalized prescribing, I think very much preaching to the choir here. Great, we can use genetic information to increase efficacy and decrease risk of adverse drug reactions. It's excellent, right? All super, very exciting. Yes, I think it is, but I also think there's a rather important caveat around representation in data, diverse groups, and health equality. And I think it's quite important that we think about that prospectively so that everything we do is informed by a wish to use and leverage this wonderful genomic data that we have at the bench to bring health equality and make health more equal in terms of outcomes for people at the bedside, rather than sort of inadvertently worsening those health inequalities with our sort of underrepresentation of diverse groups. So for these reasons, I was really keen with our research locally to represent our local population and work with people that I prescribe for as a clinician in the hospital. And I was really lucky to have the opportunity to work with the Genes and Health, a population genetic study led by Professor David Van Heel at Queen Mary. And they've done a really spectacular job of recruiting now over 50,000 participants, all of self-declared Bangladeshi or Pakistani ancestry. Now, this is a really important ancestry group in the UK. The population has gone from 5 to 10% South Asian population in the UK between the last two census points. So a really rapidly growing demographic. and one that sadly is quite underrepresented both in genetic studies, therapeutics trials, and also pharmacogenomic studies. It's also a cohort that we know is sadly much more likely than European ancestry compatriots to suffer from high rates of cardiometabolic disease. So high rate of morbidity, and that's really important then to represent. So I told you this population isn't well represented in medication trials, but don't take my word for it. These are the studies that underpin the licensure from the EMA for efficacy and safety of clopidogrel. And despite representing a quarter of the world's population, there's no representation whatsoever from South Asian ancestry participants in any of these trials. Now, I'm not showing this to you because I think this is exceptional. It's unfortunate, but it's not exceptional. I'm showing it because actually it's representative, and I think it behooves us to remember that. So we really wanted to leverage genomic data from this underrepresented group to look at medication response for these participants that are underrepresented. So we've done a few studies that I want to sort of talk about briefly to sort of just illustrate why this might be useful. So one is looking at clopidogrel efficacy in secondary myocardial infarction prevention. Another is to see if we can leverage well-validated pharmacokinetic pharmacogenes to give novel insights into purported relationship between medications and adverse drug reactions. To use real-world data to see if we can understand from genotype if there's sort of an increased prevalence of people experiencing gastrointestinal bleeds with serotonergic antidepressants, and to look at the impact of baseline risk in terms of medical comorbidity in this deprived and sort of higher-risk population, to see how that baseline risk of venothromboembolism can then impact with genetic risk, and how that then is compounded by medication use for estrogen, which we know to be prothrombotic. So these all follow a general flow, which is using well-validated pharmacogenes, looking at the prevalence in this specific population, using the very good medication data that we are really fortunate to have due to excellent linkage with primary care CCGs. So this is really remarkable because this means for 86% of the participants roughly, we have lifelong complete primary care prescribing data, which is really a boon for pharmacogenomics research. Linking that with real-world health outcome data, that's from electronic healthcare records, and lastly, talking to participants so that we have that level of public engagement and see what those people who've contributed the data think of this. So very briefly, to go into this study on clopidogrel efficacy, as we know, clopidogrel is an antiplatelet agent, P2Y12 inhibitor, commonly used for secondary prevention after ischemic events, particularly myocardial infarction. It's a prodrug, so it needs to be activated in the body by one of those CYP450 enzymes, CYP2C19, for it to be active and therefore to have the benefit. Now, the CYP2C19 gene is encoded by the enzyme of the same name, and we know that polymorphisms that account for loss of function are really common in that gene. And there have been a lot of studies that show you that loss of function variants in this gene are associated with high on-treatment platelet reactivity and increased risk of secondary ischemic events. So if you have the genetic variant, that means that you can't produce the enzyme, you can't activate the drug, and it doesn't work for you. I said these variants are really common, and they are, but there's a catch. So 1 in every 3 people of European ancestry has one, but we know that prevalence from population genetic studies are much higher in Asian and Oceanic groups. The issue is that there have been a dearth of studies linking those genetic variants with medication exposure and health outcomes for these underrepresented groups. So we wanted to use this data to do a very simple validation study looking at the prevalence of these well-characterized CYP2C19 loss of function alleles and to see if those are then associated with sort of non-granular health outcome data level real-world events. So in summary, we found that participants in this South Asian cohort had a really high rate of loss of function alleles. So 57% had at least one, so it's actually more than half the population. And it was 13% that had 2 and therefore were predicted to be poor metabolizers. Now that stacks up as about 4 or 5-fold more than European ancestry populations, where the poor metabolism rate would be 2 to 3%. And that's the population that we're using to inform the potential cost benefit, right, for implementation of this. So you can see that there's a bit of something that could be quite different there depending on which population we look at. And as we know, that gene variant is associated with increased risk of secondary events due to poor activation of clopidogrel. And indeed, we saw from real-world health outcome data in this very young cohort, average age at recruitment about 41, that we can already see a linkage between that genotype and quite substantial increased risk of recurrent myocardial infarction if people are prescribed clopidogrel. But pharmacogenomics also needs to focus on the burden of adverse drug reactions and how we can leverage some of this genetic data to understand more from a pharmacovigilance perspective. So we wanted to test out a proof of concept. Can we use well-validated pharmacokinetic pharmacogenes to inform us in a different way about relationships between drugs and purported adverse drug reactions? So statins, HMGA co-reductase inhibitors, indicated to treat lipid disorders and very widely used for the prevention of cardiovascular disease. The SLC01B1 gene we've already heard about today encodes a hepatic transport enzyme, which is responsible for the uptake and then clearance of statins. So we know that there's a very well-characterized polymorphism, which is responsible for a decreased function protein and therefore leads to increased exposure of statins, right? So we wanted to use that pharmacokinetic pharmacogene variant to answer a bit this question. We know from the literature people have claimed that there's an independent association between statin use and increased risk of cataracts, statin use and decreased risk of cataracts, or no independent relationship whatsoever. So what we did was a genotype stratified approach, and we saw that over a third of participants in this cohort had been prescribed a statin. One in every 12 of those participants had the STAR5 allele, which we're using as the genetic proxy for increased exposure to statins. And in the on-drug group only, there was a 1/3 reduction in the young onset cataracts in people who had that STAR5 variant. So in the group of people on statins, people who we know genetically will have a much higher exposure to the drug were 1/3 less likely to have a young onset cataract. So that addresses this question in a sort of new way and lends proof of concept that actually using those well-validated pharmacogenes for a genotype stratified approach can give us some potentially novel insights and new angles to looking at relationship between drug and adverse drug reaction in pharmacovigilance. So hopefully I've convinced you, if you needed an A, that we really need to look at differing populations who have different prevalence of pharmacogenes, who have different prevalence of the disease of interest, and who have different levels of exposure to the drugs of interest, right? And to implement pharmacogenomics well in all of the ways that John illustrated so nicely, we really need to work on our representation problem. And we need to talk to patients because, as we've heard, the issues that people might have when you implement into clinical practice are really different from the issues that you might think about at validation level. And anyone at either side of a doctor-patient desk will know that concerns can differ. So for this reason, we did some focus groups. We wanted to talk to these participants, and we were very fortunate to be able to do this with the Genes in Health study. And we wanted to talk to them again because they're underrepresented but suffer from high rates of multimorbidity and therefore a really high level of exposure to polypharmacy. And that won't surprise anyone that treats these patients on a regular basis. So we did 4 focus groups, semi-structured in nature, 9 to 12 participants in each group, and a brief survey was taken before discussion. We were really fortunate to have simultaneous interpretation in Urdu and Bengali, and focus groups were recorded, transcribed, and then analyzed. So who were these people? There were 42 in total, about 64% female, 26% born in the UK or Europe, about half born in Bangladesh and 17% in Pakistan, and roughly a third reported university-level education. And most of that was not in European nations. The primary reported spoken language was about half English, roughly a third Bengali, and 12% Urdu. So we focused on 2 things broadly, summarizing roughly 16 hours of discussion, clinical implementation of pharmacogenomics, and then a transition to research. So participants had a lot of lived experience with themselves, with their families, about sort of a trial and error approach to medicine, and very quickly saw the benefits of a more tailored approach, and were really keen and wanted to talk about it as which medicine suits your body. And in terms of implementation, trust was the really critical issue. And it was really wonderful to see the amount of faith people had in their general practitioners. This was really beautiful. And obviously, primary care practitioners have a central role to play in any implementation of PGX. But there was also a really interesting relationship between trust, pharmacogenomics, and compliance. So even if participants had a really high level of confidence in their GP, they didn't necessarily believe that these medicines were sort of targeted to them. So they might not take the full dose or exactly as many days as was prescribed, but people did feel that if they knew there was an empiric pharmacogenomic test that said this medicine is likely to suit your body, just the knowledge of that test actually would make them much more likely to be compliant with the prescription. Now we shifted topics. We said, okay, we've got a national fingerprint for pharmacogenomics. We've done it, yay. That information is clearly going to be of interest, right, for research. So regulators, academics, but also industry are obviously going to have some interest in that. So then what do you think prospectively? Say we've done that, next step. What do you think about using that information for research? What would you like? What would you not like? And people really strongly supported sort of any presence of their community as represented in research. And there was this really wonderful example where presence of their community in research had led to behavioral changes. So someone said, okay, we had this research disseminated in mosque where we learned that people of South Asian ancestry who have vitamin D deficiency in Western countries have some bad outcomes from that. So everyone I know then started to take vitamin D. Right? So there's some real behavioral benefits potentially of seeing that representation. But trust was a really big issue. And I know we've heard about some of this already and things we know like confidentiality, privacy, gated data access, data ownership, really big issues that people have a lot of concerns around. But also people were really concerned about potential price gouging by private interests. So there was a big concern that if private industry figured out which groups of people were particularly well suited to which medicines, then that information would lead to price gouging, people would be charged more for the medicines they needed, and benefits would not be shared. So in summary, implementation of pharmacogenomics was perceived to be beneficial to the individual, but pose a risk of overburdening an already resource-burdened and limited system. The research with that data was perceived to be beneficial to the community, but with concerns about data privacy and misuse. And data sharing was desirable, but only if the researchers didn't have a financial stake and benefits would be shared. And the really interesting, I think, component of this was the central aspect of trust. And I think that's something we already know, but needs to be really clearly articulated, right? To solve these issues, we need to work on trust. And there was this interesting loop where people thought if they have a pharmacogenomics test, they have more confidence that this is right for them. They're more likely to take their medicine. If they see this in action, then they're more likely to get involved in pharmacogenomic research. And if they see their community represented in pharmacogenomic research, again, people are going to be much more likely to take that medicine. So what we're hoping to do with the Network of Excellence, some very broad national surveys of pharmacogenomic awareness and aspects of implementation, focus groups to enhance for underrepresented groups, and policy advocacy, so that if people generously give us their time and their opinions, we honour that by trying to do something about it. So what we want to do with all that is ensure that we're working to target inequality with these wonderful tools that we've been provided, bringing it from the bench to the bedside instead of making it worse. And the development of appropriate patient-facing materials will be really critical to do this. So how much help will we need? A huge amount of help. This is a massive, massive undertaking, and we need everyone here and all of the networks and many more people and many more networks. So yes, thank you so much to everyone who contributed to this, and thank you for your time.
Wonderful work, Emma. We'll have opportunity if you want to speak to Emma, want to get engaged, want to find out a little bit more. Emma's here all day, so thank you very much for that. So next, Munir is going to talk a little bit about the programme and the work package around cancer pharmacogenomics. Thank you.
Thanks, Bill. So I'm just going to take you through very quickly in terms of what we're doing within the network on cancer pharmacogenomics. It's very much a discovery type study. Now, when you are prescribing a drug, you look at the benefits and risks, and you want to maximize benefit and minimize risks. In cancer, you often have to accept a degree of risk because you're trying to treat the cancer and hopefully cure the cancer and get progression-free survival. And to some extent, oncologists have accepted that you get a degree of risk in terms of serious side effects, etc. But unfortunately, those serious side effects can sometimes be long-lasting and create major problems, survivor issues, and so on. And although cancer is said to be the poster child of precision medicine, pharmacogenomics, it's only half the story. It's really very much focusing on efficacy. And we really need to do some more work on the safety to improve aspects in terms of safety of cancer drugs, in which case we can actually further maximize the benefit to risk ratio of the medicines we use in cancer. And this is clearly happening now with DPD, dihydropyrimidine dehydrogenase, introduced into the UK in about October 2020, with 4 variants being tested, and England, I think 38,000 tests per year. Work which has been done within the network by Nisha, etc., shows how well it's working, with almost everybody getting it with turnaround time, mostly about 5 days and so on. And just following on from Emma's talk, this is very much derived from European populations. So it's, if you are of a different ethnic group, then you still get the 4 variants, but that may not necessarily be relevant for you. So we have done a systematic review as part of this, working with the NHS Race and Health Observatory. And I won't show you all the data on all the different groups, but the one that we come down on is the African American group. And when in our systematic review, they had 19 variants in 3 different case studies and so on. But the most important one really was this one, C557A to G, which is reported in 3 different case studies. Is tyrosine to cysteine substitution, decreases enzyme function, and CP evidence level is moderate. There's a 2% frequency in African reference population. And this DPYD test is actually included in several laboratories in the United States, and I was talking to somebody in Australia, and they've also got it in Australia as well, but we don't have it. Whereas if you look at the UK Census 2021 population, 4.2% of the population identify themselves as Black British ethnic group. So we feel it's beneficial to include this particular variant into the NHS DPYD testing, and hopefully we will be able to work with the NHS Genomics Unit, with the British Oncology Pharmacists Association, and with the NHS Health and Race Observatory to put in an application to the Genetic Test Directory to be able to implement that. We've already got DPYD testing. It's just a matter of actually adding an extra variant to this. So hopefully that should be relatively simple. But we need to go further. As part of the Network of Excellence, we want to look at 3 different areas now, and take different approaches in terms of how we want to be able to get the evidence base for these 3 areas. The first one is UGT1A1 and irinotecan. So I think Ron was going to be here, but I don't think he's here yet, is he? But Ron van Schaik, various others, Henke and Kukela, Jesse Swen, etc., were involved in this study. This is a prospective, non-randomized study where they did pre-therapeutic genotyping for 2 alleles in UGT1A1 in people who were going to go on to irinotecan. And when you were a homozygous variant carrier, you received 30% dose reduction, and they looked at 350 evaluable patients, 8.9% were poor metabolizers. And the primary outcome was incidence of febrile neutropenia. And what they found was that the febrile neutropenia in poor metabolizers who received a 30% dose reduction was 6.5%, which is equivalent to non-poor metabolizers, compared to 24% in historical control where there was no genotyping done. The systemic exposure to the main metabolite of irinotecan was 32% higher, so suggesting that maybe 30% dose reduction was maybe too small a dose reduction, but you could have reduced it a bit more, but still pretty good. And they also showed it was cost reduction of 183 euros per patient by doing this. So this is now being utilized, I think, on almost everybody in the Netherlands. I got an email from Ron last week saying that it is actually being used on almost everybody in the Netherlands now. And if you look at what the guidelines say, the Dutch guidelines show that you should reduce dose by 70% of the normal dose. And then it can be increased depending on whether the patient tolerates the initial dose. CPIC doesn't have a guideline on this at the moment, but the French do, and the French also suggest a 25 to 30% dose reduction at first cycle, particularly in cases associated with performance status and so on. And if you are star 28, irinotecan is contraindicated when you give a very high dose of greater than 240 milligrams per meter squared. Now, it's very much dependent on dose. Clearly, in the past, when irinotecan was first introduced, the doses were much higher than they are being used now. But nevertheless, the lower the dose, the lower the risk. But nevertheless, you are still at higher risk if you do carry the STAR 2828. And the Italian Society of Pharmacology also has guidelines on this. And if you look at some of the new drugs which are coming out, and this is an antibody drug conjugate, and the antibody binds to a particular ligand on breast cancer cells and then releases SN38, which is the active metabolite, into the cancer cells to kill off the cancer. This also is associated with grade 3 neutropenia and diarrhea. And so these are 5 different studies, which are trials, which have been done in the literature, and Cynthia has done the hard work on this. And you can see that a grade 3 neutropenia was greater in all the studies where genotyping was done. So STAR 2828 had higher rates of the neutropenia, again, highlighting the evidence base that's there. So what we're trying to do as part of this is to really gather the evidence base and see whether then we can work with oncologists and so on and get their views in terms of how to take this forward into the NHS test directory, because this is being used increasingly in clinical practice. So the next one is been around for a long time. It's an old drug, anthracyclines, doxorubicin, daunorubicin, epirubicin. And it causes heart problems, cardiotoxicity. In high-risk patients, heart failure can occur in up to 5% of patients. And when you get heart failure, this is not just an acute condition. It is a lifelong condition which affects your morbidity and mortality. And you can see the cardiac events rates increase with cumulative dosage. And when you get the highest dose, 65% of people will get this. And in a cohort study, the incidence was about 9%, with 98% developing it within the first year, median time of 3.5 months. And Maria, thank you to Maria for some of the slides here. So if you look at the cardiotoxicity, the key issue that we need to sort out by taking this work is trying to sort out the phenotype. What is the phenotype that we're going to use? And this is work that we are undertaking. Maria is leading this work with oncologists here and in Manchester, and cardiologists as well here in Manchester, to see whether we can actually define the best phenotype for us to be able to start recruiting patients, and then we will be able to categorize them according to this grading system. Once we've got the phenotype sorted, then we can start recruiting patients, because unless you get the phenotype wrong, it's not going to help. Now, if you look at the Canadian example, Bruce Carlton and his colleagues have been doing some work on this in children, but no work has been done on adults on these 3 particular polymorphisms. And they've shown in for these three particular polymorphisms that there is a consistent association, and they actually use it for risk stratification. And when you have a high risk, you get increased frequency of echocardiography and cardiovascular risk factors aggressively managed. And low risk, you have cardiac follow-up every 5 years. So the risk stratifying based on these 3 variants in British Columbia at the moment. It's not been implemented throughout the whole of Canada, but in British Columbia, it is implemented in that way. So it's important for us to be able to see, are these relevant for adults? And what does it actually tell us? And can we actually then identify other new variants as well? So this is something that we're going to hopefully start recruiting very soon in Manchester and Liverpool initially, but then hopefully wider as well. So I'm going to go to the next one. So the last one is immune checkpoint inhibitors, very widely used now. Myocarditis is perhaps the most severest of the adverse events which occurs, immune adverse events which occurs in about 0.3 to 1.4% of patients. Male, more sort of higher risk, but also older age, diabetes, etc. And you find that it's 4.5-fold more common with combination immune checkpoint inhibitor therapy compared with single immune checkpoint inhibitor therapy. And most people will develop it within 35 days of having started the immune checkpoint inhibitors. Like I said, this is one of the sort of most severest. When it was first recognized the mortality was 40%. Now the oncologists have got more used to this. The mortality rate is coming down, which is important, but nevertheless, you're left with lifelong morbidity after that. Clear critical issue for us at the moment is then to sort out what the diagnostic criteria for us to be able to recruit to this. And there are some expert opinions out there in terms of how you diagnose immune checkpoint inhibitor myocarditis. So it could be a pathohistological diagnosis, and that would be the gold standard. But obviously, you can't do a cardiac biopsy on everybody who's having this kind of adverse effect. So what people have gone on to do is to clinical diagnosis where you have troponin elevation and some of the major or minor criteria that are listed on the slide in terms of recruiting. Again, we need to work with oncologists and cardiologists to be able to define those. But I know across the road in Clatterbridge, they have been undertaking MRI scanning on these individuals, which is probably the best form of imaging that you can undertake. And they've already identified 16 cases for me to be able to recruit to this. So we're going to sort of have 16 cases in the next couple of weeks to be able to start off the work on this. And we have done some work previously. So Anna Olsen-Brown, who did a PhD thesis with me, she's now a consultant oncologist, did some work in a PhD in 5 cases at that time. It was sort of, very early on. And she identified some particular variants that were more common in cases. And in fact, the similar things were seen in a 2016 paper in the New England Journal of Medicine, where 2 patients who died were positive for this HLA-DQB1 allele as well. So it does seem the HLA-DQ3 serotype is worth further investigation in larger numbers, so we can then start developing to see what the positive predictive values are for this. And again, HLA is important now for over 30 different drug gene pair associations. And as we move forward, it will be important to make sure that we can capture some of these immune-related adverse events which are occurring with the widespread use of immune checkpoint inhibitors that are coming through. So just to finish off, and I'm trying to keep to time, 3 drug-related toxicities in terms of discovery will be investigated. Irinotecan may be literature-based evaluation and to see what else is going on elsewhere in the world, but patient recruitment is needed for anthracycline cardiotoxicity and ICI-related myocarditis. We're going to start in Liverpool and Manchester, but keen to collaborate nationally. And there's lots of pharmacists who are interested in this, so really keen to be able to work with you on this. And if you can help, then please contact me. So because I think this is a really important area where we can try really swing the dial, if you like. And I got that phrase from after the budget yesterday. Did he swing the dial? So I'm starting to use it. So I should stop that. Sorry. But can we sort of improve the benefit risk ratio for our patients? Thanks very much for your attention.